Okay, everyone, welcome to today's acid base seminar. I thought I would review for you today hypokalemic RTAs and just a little bit about the history. The terminology that you might have heard of, type 1, type 2, type 3, actually came from San Francisco in the 1960s from Tony Sebastian. He was a renal fellow at the time. He worked for Curtis Morris, and it's a bit confusing, but we're now stuck with it. So proximal RTA is called type 2 RTA. You would think it would be called type 1 because it's the earliest part of the proximal tubule. Distal RTA is called type 1. There's a type 3 RTA, which is a mixture of type 1 and type 2. And then there's a type 4 RTA, which is a bit confusing because it does not mean hyporenin hypoaldo, like many people think. It really should be called hyperkalemic distal RTA, which could be due to hyporenin hypoaldo, but that's only one of a number of different causes. Some people actually distinguish hyperkalemic distal RTA from type 4 RTA also. We won't be talking about the hyperkalemic distal RTAs today. We'll be talking about RTA that's associated with hypokalemia. And as most things in medicine and nephrology, they can be divided up into genetic and acquired causes. So I'm going to focus a lot today on transport in the nephron of protons and bicarbonate with respect to the pathophysiology of the RTAs. To understand what's going on in the RTAs, you really have to back up and first understand what affects the plasma bicarbonate and how the kidney modulates it to keep it at 24, 25 milliequivalents per liter. So before getting into the RTAs and how we think about it, I'm going to first talk about the physiology of proton transport in the nephron. So even prior to that is the question of where the word RTA or the concepts of RTA appeared in the literature. And really, if you go back in time, the first evidence that there was such an entity really wasn't associated with an acid-base abnormality. It was Lightwood, and it was a pathology article where, in retrospect, children who had RTA were likely being described, even though it wasn't well recognized at the time. And what he described were pathologic changes in the kidneys of infants, where there was calcification of the kidney that we now call nephrocalcinosis. And in retrospect, these patients probably had distal RTA. It wasn't until the 1950s in an article by Pinnis where the term renal tubular acidosis first appeared in the literature, and it was associated with bone abnormalities. We now know, after a lot of work in the 20th century, that this is a spectrum of disorders that are associated phenomenologically with a normal anion gap metabolic acidosis. There's an abnormality in either renal bicarbonate absorption or bicarbonate generation, and we'll talk about both because these are the two primary processes by which the kidney keeps the plasma bicarbonate at 25. But it's also associated with electrolyte abnormalities that are not involving the acid-base abnormality. So it isn't just an acid-base abnormality. There are also abnormalities in renal ammonium, calcium, potassium, and water homeostasis. So these disorders affect other transport processes in the nephron, in addition to just a bicarbonate physiology. And clinically, there's outside the kidney extrarenal manifestations that can also help provide you with the etiologic diagnosis. And you'll get these on your renal board. So it's important to know the phenomenology outside the kidney abnormalities also. So now we'll go into how the kidney keeps the bicarbonate concentration in your blood at 25 millimoles per liter. And that's one of the abnormalities that is associated with RTA, and an abnormality of abnormal bicarbonate absorption. And that's what we'll talk about now. So the kidney has a problem. Bicarbonate is freely filtered through our millions of glomeruli. And if nothing else happened, it would end up in the toilet. So even without knowing anything, there must be a mechanism for reclaiming the bicarbonate from the glomerular filtrate. And if you just do the math, the plasma bicarbonate's around 25 millimolar, and our GFR is about 140 liters a day. So we filter about 72-liter bottles of Coca-Cola, if you want to think of it like that, every single day. In each liter is 25 millimolar. Millimoles. If you want to multiply the two together, you will end up with how much bicarbonate is coming through all our glomeruli, and that works out to about 3.5 moles a day, which is a bit less than a box of Arm & Hammer baking soda. So if you want to think of it pictorially, every day your kidney is absorbing an entire box of baking soda every single day. Now, if that didn't occur, given the volume of distribution of the bicarbonate, in about 4 hours, your blood bicarbonate would be 0. So if you just filtered it and there was nothing else happening after your glomeruli, if we just had glomeruli and we didn't have a nephron, then in 4 hours, your blood bicarbonate would be 0. So clearly something else must be happening. And what all mammals have are proximal tubules, and proximal tubules have many different transport proteins, but there's a whole set of machinery, transport machinery, that allow the bicarbonate to get from the glomerular filtrate into the cell, and then from the cell into the blood. So we'll demonstrate what happens now, not only in the human, but all mammals. The mechanisms here are identical. So on the apical membrane, the membrane that is facing the glomerular filtrate, there's a protein called NHE3. There's actually 8 NHEs in the mammalian genome. NHE stands for sodium hydrogen exchanger. So this protein transports a sodium in one direction and a proton in the other. And sodium enters the cell because in the glomerular filtrate, the sodium's up around 140, 150. Well, in the water phase, it's 150 milliequivalents per liter. It's 140 because 7% of our plasma is protein and lipid. So we actually are always getting a diluted result. But in the aqueous phase, it's around 150. In the cell, the sodium concentration is around 20 or 30 millimolar. So in all the cells in our body, the sodium is much lower because we have a sodium potassium ATPase on the basolateral membrane that pumps sodium out. So there's a chemical gradient for sodium to enter the cell, and protons then are driven out of the cell thermodynamically, in addition to the fact that the pH in all cells is about 7.2, 7.15, 7.2. Here in the glomerular filtrate, it's 7.4. So there's a proton gradient also. So there's a sodium gradient in and a proton gradient out, and this thing functions this way, and you end up acidifying the glomerular filtrate. There's also a proton ATPase that we'll talk about a bit later because it's mutated in distal RTA. The major cause for protons to be secreted is not the proton pump, it's NHE3. It's about 80% of the proton secretions from this protein. So when the protons get in the lumen, they combine with bicarbonate from the glomerular filtrate because you've changed the equilibrium of the bicarbonate buffer reaction, driving it towards bicarbonate consumption as the pH drops. And you end up forming carbon dioxide and water in the lumen of the tubule. Well, you still haven't absorbed bicarbonate. You've just gotten rid of the bicarbonate by turning it into carbon dioxide. Next thing that happens is the water and also the CO2, which most people don't appreciate, go through the apical membrane because now you've created a gradient for carbon dioxide and water between the lumen and the cell. You've generated more of this, and these things will then enter down their concentration gradients through aquaporin 1. It's known that the water goes through aquaporin 1. It's not as well known that the gaseous form of this reaction also goes through. The carbon dioxide also permeates aquaporin 1. They enter the cell, and then they create an out of equilibrium reaction in the cell where you get the opposite occurring. I might add that both of these are catalyzed by carbonic anhydrases. There's at least 14 different carbonic anhydrases in the human genome. They all catalyze this reaction, either in the forward or the reverse reaction. And carbonic anhydrase 4 is not obviously floating free in solution. It doesn't get through the glomerulus. It's attached to the apical membrane by what's called a GP1 anchor. It's a protein that's attached to the apical membrane here, and it also binds carbonic anhydrase 4. So carbonic anhydrase 4 is sort of, you can think of it like a tree sitting on the apical membrane, catalyzing this reaction. In the cell, there's another carbonic anhydrase called carbonic anhydrase 2 that's freely floating around in the cytoplasm. So it catalyzes this reverse reaction. And then the proton is released, which then just recycles. There's actually 2 protons released from the carbonic acid, and you also make carbonate. I'm not showing the bicarbonate creation here, but it also occurs. The bicarbonate then is converted into carbonate ultimately. And what happens next is the carbonate then leaves the cell on a protein called NBCE1A, which we've studied for many, many years. It's coupled to sodium, and these 2 things just leave the cell. So what you've now done is you've gotten the bicarbonate that came through the glomerulus, converted to carbon dioxide. Carbon dioxide enters the cell, and then you regenerate carbonate, and it's the carbonate that leaves. So that's how bicarbonate is reclaimed by the mammalian proximal tubule. It's a bunch of indirect processes. There's no direct process of physiologic importance that takes bicarbonate intact from the glomerular filtrate into the cell, and then from the cell to the basolateral membrane. It's all indirect by converting bicarbonate first into carbon dioxide, and then converting the carbon dioxide into carbonate. Now, this transporter is called electrogenic because it carries a current. You can see that the carbonate has 2 negative charges on it, and the sodium only has 1. So it carries a negative charge, and it's therefore sees the charge on the basolateral membrane of the cell. All cells in our body, including the proximal tubule, are more negative inside than outside in the steady state. So there's a voltage here that is a driving force for driving the carbonate and sodium out. In fact, the chemical gradients are the wrong way. The carbonate concentration in plasma is greater than the cell, and the sodium, as we said before, is greater than the cell. So if it was just these 2 things, they would be going back into the cell, and cell would never be able to absorb the bicarbonate. It's because this thing is electrogenic and carries a current that it sees the voltage on the basolateral membrane, and it just turns out mathematically that the thermodynamic driving force that the voltage causes exceeds the chemical gradients that are inward. So the voltage driving force out is greater than these 2 things, and you end up with a net driving force out. The voltage is created by the sodium pump. Remember, there's 3 sodiums and 2 potassiums that are transported here. They're not equal, and that creates part of the voltage. And then there's what's called a diffusion potential created by potassium leaking out of the cell. Potassium inside cells is not 4 or 5, it's 110 millimolar. So potassium leaks out through this channel and creates what's called a diffusion potential. And so it's very important to have normal functioning sodium potassium ATPase in order for carbonate to get out of the cell on NBCE1A. So that's a very brief tour of the transport machinery. We'll go over this a number of times. You're going to be asked about this stuff on your boards because there's a number of proteins in this region of the tubule that are mutated in the RTAs, and we'll go over some of it today. So that process is one process that has to occur. You have to be able to reclaim the bicarbonate from the glomerular filtrate. The other process that has to occur is the following. Every day from our diet, on an average North American diet, you make hydrochloric and sulfuric acid. I'm not showing the anions here, but the protons come out of the liver in the form of hydrochloric and sulfuric acid, and they will bind to bicarbonate in your blood after they get into the blood from the hepatic vein into the inferior vena cava. and consume bicarbonate. You will then generate carbon dioxide and water. You excrete the carbon dioxide in your lungs. You're fine as far as your PCO2, which this would represent, but now you're going to have a lower bicarbonate concentration. The same thing occurs in lactic acidosis or ketoacidosis or any organic anion acidosis. It's just this is occurring normally. We don't think about it. And the acids are hydrochloric and some sulfuric acid. So this is occurring normally. We normally have a proton load. It's just that when you get an organic acidosis, it's quantitatively much more than this process here. And the amount of protons is about 50 to 60 milliequivalents a day. Now, if this kept occurring and nothing else happened, if you do the math as far as the volume of distribution and how many protons are made every day from your diet, you can calculate that in about 14 days, roughly 2 weeks or so, this would go to zero. Now, the proton input into the blood is not a fixed number. It depends what we eat. So and people come up with these kind of charts where you have acid producing foods and base producing foods. If you're eating cheeses and egg yolk, meat and fish, you're going to be producing a lot of hydrochloric and sulfuric acid, as opposed to vegetables, spinach, raisins. They produce bicarbonate. So you don't have a proton load if you're just eating these things. And we eat a combination of these things. And that has changed historically too, because around 10,000 years ago, humans used to eat a lot more protein. They had a much bigger proton load, but 10,000 years ago, we started to develop farming and became more herbivores. And if you look at this kind of chart, you can actually create an animal to plant ratio in the diet and predict what the proton load will be. And if the animal to plant ratio is about 60%, then you have what's called a net acid production of about zero. So to the extent that the animal to plant ratio increases above 60, you start making more and more protons. And an average North American diet is not a 60% ratio. It's more like 80, 85%, which is why we, in a net sense, generate protons from our diet. And that can't be allowed to occur without something else happening. Even if we have normal bicarbonate reclamation in the proximal tubule, this proton production, which is occurring, will lower our blood bicarbonate concentration eventually, unless something else is done. So here's the problem. If you just back out to 30,000 feet and look at the whole human body, on an average North American diet, you're producing about 50 milliequivalents of protons a day, mainly from the liver. And this red square here is our body. That can't be allowed to occur. Otherwise, we're going to be dropping our bicarbonate concentration. It's no different than starting a hydrochloric acid drip in a patient. Just realize that this is occurring in all of us daily. Well, what turns out is that the kidney is able to generate bicarbonate. And I'm not saying reclaim bicarbonate. I'm saying generate bicarbonate above the reclamation that we just talked about in earlier slides, that matches the daily hepatic proton load. So the liver is making protons. The hepatic vein is actually an acid IV. And the kidney, you can think of it as a bicarbonate IV. So the renal vein is putting net bicarbonate back into the body, and the hepatic vein is putting protons in there, and they roughly match. And that's why, despite the hepatic proton load from our diet, the blood bicarbonate concentration doesn't fall. We do generate carbon dioxide, but that's just excreted by the lungs. So that doesn't end up being an issue, and we end up with a normal blood bicarbonate concentration. So this is the second process that must occur in order for the blood bicarbonate concentration to stay at 25. You have to be able to reclaim it, as we showed earlier in the proximal tubule, and you have to match your daily hepatic proton load. Either of these general processes, if they're defective, will lead to renal tubular acidosis. So the question then is, how does the proximal tubule, or how does the nephron, in a general sense, create new bicarbonate? This is separate from reclaiming the bicarbonate from the glomerular filtrate that we showed with those different transporters. We're now talking about creating new bicarbonate that didn't exist before. Well, it turns out the kidney does it mainly from something called alpha-ketoglutarate. Alpha-ketoglutarate is derived from glutamine. Mostly it comes in from the apical membrane. It's one of the amino acids in our diet. It's in all proteins that we eat. Glutamine can also come from the basolateral side, but less than the apical side. And in the mitochondria of the proximal tubule, glutamine is turned into alpha-ketoglutarate. The alpha-ketoglutarate enters the Krebs cycle, and in the Krebs cycle, the carboxyl groups, there's 2 carboxyl groups on this. It's an organic anion with 2 carboxyl groups. Those carboxyl groups are neutralized and turned into bicarbonate. The 2 bicarbonate ions leave as 2 carbonate ions on NBCE1A that we showed before on the basolateral membrane and end up in the renal vein. Now, the problem with this process is that in addition to the 2 bicarbonate ions that are made in the Krebs cycle, there's 2 ammonium ions made. This is where the ammonia comes from, by the way, in our urine. It comes from alpha-ketoglutarate, or the reactions that make alpha-ketoglutarate from glutamine in the mitochondria of the proximal tubule. So yes, it's very good that we generate new bicarbonate from this reaction to match our daily hepatic proton load, but one of the byproducts of this reaction is ammonium. Now we'll talk about why that's not a good thing in just a minute. So if someone asks you, where does the ammonia come from in the urine? Most of it's coming from glutamine metabolism to alpha-ketoglutarate. And your brain should associate that process with, in addition, the generation of bicarbonate to match the daily hepatic proton load. So when you see ammonia in the urine, you know inferentially that you've also made new bicarbonate. That's why there's ammonia in the urine. Now, the question then is, if the ammonia derived from glutamine were transferred to the renal vein with the bicarbonate produced from alpha-ketoglutarate, instead of ending up in the urine, and we haven't talked about how that ammonia gets in the urine yet, but if it was sent back to the renal vein in the proximal tubule with the new bicarbonate that is sent back to the renal vein on NBCE1A, why is that a problem? Why do we have to have ammonia, or at least some of it, end up in the urine? Why can't we just send this byproduct back to the renal vein also? And the answer is the bicarbonate would be consumed in the urea cycle. So instead of the bicarbonate being free to match the daily hepatic proton load and preventing us from getting a metabolic acidosis from the protons made in the liver, the bicarbonate would not be able to do that and would end up in the urea cycle, because the urea cycle, when you look at it, urea is made from 2 bicarbonate and 2 ammonium ions. When you look at the net biochemistry of the urea cycle, you're basically taking 2 bicarbonate ions and 2 ammonium ions and turning it into this substance called urea. There's some water and carbon dioxide made too, but this is what the urea cycle does. Urea comes from 2 bicarbonate and 2 ammonium ions. So if the bicarbonate was sent across the basolateral membrane, or the carbonate, into the renal vein, and the proximal tubule took the ammonium that was made in that reaction and also sent it across the basolateral membrane, both of these substances would just be turned into urea, and all you'd be doing would be taking glutamine and turning it into urea, which would be fine to do. The problem is you wouldn't do anything for your acid-base status, and you'd end up slowly with a metabolic acidosis. It turns out, as we'll talk about in later talks, this is the mechanism for metabolic acidosis in CKD and in ESRD. The kidney, as you go through the CKD stages and finally end up with the ESRD, has a harder and harder time taking glutamine and converting it into alpha-ketoglutarate. The glutamine uptake by the kidney in CKD, as you get to worse and worse stages, and in ESRD especially, is impaired. And so the reason for the metabolic acidosis is you can't generate alpha-ketoglutarate as easily, and then therefore you can't generate new bicarbonate as easily. So people with CKD and ESRD have impaired ability to match their daily hepatic proton load. That's the answer if an attending asks you why this patient with CKD has a lower bicarbonate. That's why the bicarbonate drops. If you see it's not dropping, you know that their ability to, either one of two things is happening. If you have a patient with CKD 4 or 5 and their bicarbonate's normal and they're not on treatment, either the ability of the kidney to take up glutamine and turn it into new bicarbonate is still intact, or the patient's not eating a diet that's generating a lot of protons. You can change, people don't think about it, but you can easily, if the patient will comply, change their bicarbonate, not by giving them bicarbonate, but just by changing their hepatic proton load. If you cut back on the cheeses and some of the things in their diet that are producing a lot of protons and put them on raisins, for example, as per that other slide, or base producing food, you can also modulate their blood bicarbonate that easily too. It's just no one ever thinks about it. You don't have to give them bicarbonate. The problem is patients, usually don't want to change their diets. But so when you see someone with a normal bicarbonate with ESRD or CKD, it's unusual, and it's either because the kidney still is able to generate new bicarbonate, or it's the type of diet they're eating, or both. So that's just an interesting aside. We won't talk about the impairment in glutamine uptake today.
Dr. Kurtz, this is Ramon. I have a question. One thing that I've never quite understood is how normalizing bicarbonate helps slow down CKD progression. I'm just thinking about this mechanism. I'm not sure if I understand how that works.
This is a whole lecture in and of itself, which we'll talk about. I mean, that's an important question. It's not so clear that it does. It's still controversial, even though most people are sort of accepting it because it's an easy thing to do. It's not clear that it does, and it's not clear that it does it with all causes of CKD. It's an in vogue sort of topic now that people have been looking at for 3 or 4 years or so. We'll talk about that. And there are also other causes of metabolic acidosis where people don't even get CKD. So it's a confusing topic. Similarly to the top, what's the chicken and what's the egg? It's the same
with hypertension and that.
Yeah, it's the same type of. Does hypertension cause CKD, or is the CKD causing the hypertension? What's the chicken and what's the egg? But it's a confusing topic, and therefore it really can't be answered in a short sentence. We'll talk about that separately. There's also papers now on what's called eubicarbonatemic metabolic acidosis, where people think that even if your bicarbonate is normal, but you're not able to generate new bicarbonate normally, and people look at the citrate excretion in the urine. We'll talk about that. That they may even be prone to having worse CKD progression, even if the bicarbonate's normal. So it's a confusing topic, and it's a good question, and it's the key question. How, if it's even doing it, does it alter the progression of CKD? We'll talk about that.
Thank you.
But just so that you realize, when you ask a group of nephrologists, what's the mechanism of metabolic acidosis and CKD, you're going to get 10 different answers. The correct answer in most patients is that they can't generate new bicarbonate normally, because glutamine uptake, when CKD starts to really progress and get severe, becomes severely impaired, and they don't have a source of new bicarbonate. They don't have the alpha-ketoglutarate with its 2 carboxyl groups that can enter the Krebs cycle. So that's the mechanism. Okay, so why still, we come back to the question. We have this substance called ammonia, and the correct chemical name is ammonium, because that's really what's produced given the pH of the cell in the mitochondrial reaction. It's not NH3, it's actually NH4 plus, which is produced. Why is it important that at least some of that comes out in the urine? And the answer is, if it gets back solely through the basolateral membrane to the renal vein, you're just going to use up all that new bicarbonate you made in a futile way, not to help you with the proton load from your diet, but you'll just be generating more urea. In fact, you can take a liver, you can take cut the liver out of the body and pump ammonia and bicarbonate into it and measure the urea that comes out in the hepatic vein. You'll just generate more and more urea, the more bicarbonate and ammonia you put into the renal vein. Okay, so we have this thing in the human body and in all mammals, a phenomena called renal ammonia partitioning, and this other concept called effective new bicarbonate generation. So we know that the bicarbonate, this is just a scanning EM of the proximal tubule here. So this is the apical membrane where NHE3 is. This is where the glomerular filtrate is. So the protons come out on NHE3. You generate carbon dioxide in the lumen. The carbon dioxide enters the cell, and the reverse reaction occurs. You make carbonate, and then carbonate leaves on MbCE1A with sodium. That's how it gets back into the blood. And basically, you absorb all the filtered bicarbonate that comes through here. Now, the proximal tubule can't absorb all the bicarbonate. There's still some bicarbonate that's absorbing the rest of the nephron, but the proximal tubule absorbs 75–80% of the bicarbonate coming through here. But the 100% doesn't represent 100% of the glomerular filtrate. It just means that all the bicarbonate that is created here and absorbed, created because of this indirect process. But the whole process is reclamation or reabsorption. 100% of that ends up across the basolateral membrane into the renal vein. None of this comes out in the urine. That's what the 100% means. Okay. Now, the ammonia, though, as I said, doesn't end up. Let's go back here. I hope that's working. I guess it's not. Okay, I had some arrows here. But at any rate, it turns out that 40% of the ammonia that's generated here does cross the basolateral membrane and end up in the renal vein. And so that part is futile. You will use up 40% of this bicarbonate that was created in the formation of urea, but it does free up 60% that can be used to match the daily hepatic proton load. You might ask, why doesn't it all end up in the urine? Why isn't it 100%? We'll talk about that another time. It probably is so that the kidney can regulate its partitioning depending on the acid-base status and what it needs to do biochemically and physiologically for your acid-base balance. Not only can it generate bicarbonate to different extents. For instance, when you have a lactic acidosis, there's a ton more bicarbonate generation than just the 50–60 milliequivalents that you normally do on your regular diet. But it also modulates the partitioning of ammonia. So normally 60% of the ammonia goes into the ultimately into the collecting duct lumen, and you end up peeing that out in the toilet. So you lose about 60% of the ammonia that was made in this reaction. And that's what you measure when you're measuring either ammonia directly, as we can do now at UCLA, or whether you measure the urine anion gap, or whether you're measuring the osmolar gap divided by 2, all these different ways. That ammonia is derived from glutamine. It gets into the collecting duct through a number of different transport processes that we won't talk today. It does get in as NHE3 from the interstitium. So that's one mechanism for new bicarbonate generation from alpha ketoglutarate. That's about, of the bicarbonate generated every day, 50–60 milliequivalents, 2/3 of it's from that alpha ketoglutarate reaction. About 1/3 of it comes from this other reaction. And what happens here is both in the proximal tubule and the collecting duct, there's additional proton secretion that doesn't reclaim bicarbonate. It actually are protons that bind to phosphate in the lumen, HPO4, turning it into H2PO4. But when that occurs, it's coming from carbonic acid in the cell. You're actually going to split the carbonic acid when you secrete that proton and make more bicarbonate. So this is called titratable acid formation or excretion. You'll see that in the physiology books and in the renal textbooks. And this is occurring both in the proximal tubule and in the collecting duct. And basically, you have protons that are not binding to bicarbonate. And again, we're showing this really artificially. The protons partition between all these different substances in the lumen. It's just that there's a component that doesn't bind protons or bind bicarbonate, it'll bind to the HPO4 here. But to the extent it does, the H2PO4 then is excreted, and every H2PO4 2- excreted is associated with an identical amount of new bicarbonate that was generated. And again, the bicarbonate just gets reclaimed on the basolateral membrane and goes back to the renal vein. So this is a component also of new bicarbonate generation. Okay, so again, just to summarize, we have this first process which absorbs, or what we call reclaims, bicarbonate in the proximal tubule through those transport processes that I showed. And then we have this second set of processes, both alpha-ketoglutarate metabolism in the Krebs cycle and proton secretion in the proximal tubule and the collecting duct that end up with protonating phosphate. Those two processes generate new bicarbonate that matches your daily hepatic proton load. We do make that byproduct called ammonium in the alpha-ketoglutarate production biochemistry, and most of that is sent into the urine to prevent that ammonia from getting back into the body, where it would just convert the new bicarbonate that you wanted to use for matching your daily hepatic proton load. It would convert it into urea, and you would lose that new bicarbonate, or what we call effective bicarbonate generation. Okay, so if any of that's not clear, please email me, because once you understand it, there's nothing more to understand. But you really have to partition the things the kidney does to keep the bicarbonate at 25 into those two processes, because there's a whole slew of renal diseases that affect those things, that once you understand the normal processes, you can then predict what's going to occur when you have abnormalities. So here is one such case. It was a 57-year-old female. She was blind. She had bilateral glaucoma, bilateral cataracts, and on an exam, she had short stature. Her cornea had opacities. Her teeth were abnormal, and there were some intellectual abnormalities. So here's a picture of her eye. These are her teeth. And you can see the calcifications here in the basal ganglia. So these cases were known for years and years until 2002, when Igarashi actually found out the genetic mutation that was going on in these patients. Here's her blood. You can see she didn't have any CKD or GFR abnormalities. She had a metabolic acidosis. Bicarbonate was 12. The PCO2 was 27. Again, these are down roughly the same amount. So you know this is a compensated metabolic acidosis. The anion gap is within the normal range. So it's a non-gap metabolic acidosis. And with this clinical phenomenology, you would expect RTA. And once you know the clinical phenotype, this is proximal RTA. And this could be on your exam. They may show you pictures like this and say, what is the acid-base abnormality when they give you the chemistries. So when we have likely RTA, we want to know first, is it proximal or distal? For proximal RTA, you have to measure the fractional excretion. That's how we diagnose proximal RTA. And we've gone over the fractional excretion of anything a number of times. You calculate it the same way. You get a spot urine and blood, plug the numbers in to the formula, and you multiply by 100 and calculate the fractional excretion. Normally, this would be very low, 1%, right? Very low. So 30%, if you're excreting 30% of the bicarbonate that's coming through your glomeruli, you've got a huge transport abnormality of bicarbonate in the tubule. And since the proximal tubule absorbs 80%, if you're excreting 30%, you know that you must have proximal tubule abnormality, because the rest of the nephron's only absorbing 20%. If I had an intact proximal tubule bicarbonate absorption and I somehow got rid of the rest of the nephron, the most the fractional excretion could be is 20%, because that's all the rest of the nephron absorbs, is 20% of the glomerular filtrate. Even if it was 0, you would still be able to absorb 80%. and you'd have a fractional excretion of 20%. So if you have a fractional excretion of 30%, it doesn't mean it's only the proximal tubule, but by definition, without doing any thinking, you must have proximal tubule bicarbonate absorption abnormality. This is like a pulmonary function test. You can think of the Fe bicarbonate as a nephron bicarbonate absorption function test. And since most of it occurs in the proximal tubule, you're essentially looking at you have a function test that you can anatomically correlate with proximal tubule function. You can't do that with these more global measurements, say where in the nephron something's abnormal. But with the fractional excretion of bicarbonate, if you have numbers like this, 30, 40, 50, 60%, you know, by definition, the proximal tubule is the problem. Now, this confuses people. How can the urine pH be 4.9? And we'll talk about that in a minute. But just remember, with all things in nephrology, you have to diagnose the initial creation of something versus the steady state. And conceptually, as applied to bicarbonate absorption, when you first create the abnormality, like if you give someone Diamox, or let's say somehow I could just poison the proximal tubule and I was there from time zero, I would find a ton of bicarbonate in the urine, and the urine pH would be high. It wouldn't be low. But what happens is, as the bicarbonate gets dumped in the toilet, the blood bicarbonate starts to fall. And as it falls, the proximal tubule can now reclaim that much impaired filtered load of bicarbonate. And eventually you won't have bicarbonate in the urine anymore, and your urine pH will become very low. It's lower than normal because the rest of the nephron is seeing that and is enhancing proton secretion in the collecting duct like crazy. We'll talk about that a different time. But when you see this, you know that the proximal tubule is absorbing what's coming through the glomerulus. Is just a lot less than it was before. Half the bicarbonate is coming. We have a normal GFR of 140 liters a day. We got half the bicarbonate coming through. The proximal tubule only has to absorb half the box of Arm & Hammer baking soda, and there'll be no bicarbonate in the urine. Not because of the tubule, but because there's just less of what we call a lower filtered load of bicarbonate. In every liter coming through a glomeruli, there's half the amount of bicarbonate. So you need to distinguish steady state from the acute situation. The same when you go on a diuretic. Your urine electrolytes are going to be different at times, you know, in the first few minutes than 2 weeks later, where you'll reach a steady state again. So again, we calculate the fractional excretion of anything this way. Creatinines are always the same. This changes depending on what you're talking about. And you multiply by 100. And conceptually, it's the amount excreted in the urine divided by how much came through all your glomeruli. And normally we absorb 99% of the filtered bicarbonate, so the fractional excretion is 1%. Okay. So this patient has isolated proximal renal tubular acidosis. If you see this and it's familial, it's always, no one's ever found any other mutations. These are mutations in NBCE1A, the protein on the basolateral membrane that where the X is here. Well, actually, the X just shows that you can't absorb bicarbonate. But NBCE1A, remember, is on the basolateral membrane. It's in the proximal tubule. It's in the proximal tubule is something that you hear of in the first year of your renal fellowship, but actually there are 3 parts of the proximal tubule, the S1, S2, S3, and they're also superficial and deep nephrons. So we actually have 6 different types of proximal tubules. They are essentially the same, but they have different transport capability. And NBC1A is in the S1 and S2 portions. The S3 portion, which is shown here, not just outside the green square, has very little NBC1A, and there's very little transepithelial bicarbonate absorption. Most of the bicarbonate absorption occurs here in the first millimeter or 2 after the glomerulus. So patients with NBC1A mutations can't absorb sodium carbonate across the basolateral membrane. And it just, the rest of the nephron doesn't have the transport machinery, and it just ends up in the toilet. When it's first created, obviously, they're born with the abnormality already. The bicarbonate's already been lost. So again, they have a problem with NBC1A. And many, many mutations have now been described in this protein. So the bicarbonate can be converted to carbon dioxide. It can get back in the cell. It can be back converted to carbonate, but now the carbonate can't get out. There's no other machinery here on the basalateral membrane of mammalian proximal tubules that can do this. So the whole thing just backs up, and you end up with bicarbonate coming to the rest of the nephron, but it doesn't have the machinery to absorb more than 20% or so. So you'll reach a new steady state when the rest of the nephron can handle the filtered load. This is just a cartoon of MBC1A. These cylinders represent transepithelial or transmembrane segments. It's a membrane protein, which means if you think of a bilayer here, so a lipid bilayer, this would be the blood side. So flip the cell sort of upward. This is the blood. This is the intracellular part. The thing weaves in and out of the membrane. You can think of a needle weaving it in and out, in and out, in and out. And this is a simple two-dimensional cartoon of it. It doesn't really look like this. But there are mutations throughout the protein. Some of them are stop codon mutations where the patient can't even make the rest of the protein. Most of them are missense. Some of them are frame shift mutations. And this is just from my lab. This is what it actually looks like. It actually looks like I don't know, a bat or something, but it's got these two monomers. It's not just a single protein. It actually has two identical monomers forming this type of shape. That's a cryo-EM picture of the transporter. And bicarbonate is actually carbonate is actually transported from the cell here through this portion of the protein. And again, there's two identical subunits. The current thinking is actually that it acts like an elevator, that the bicarbonate or carbonate enter, and this portion of the protein actually moves up with the carbonate and then takes it to the other side. This occurs probably around 50,000 times every second. That's sort of the dynamics and the rate here. We're talking about something that moves phenomenally quickly. This is just an interesting experiment of one of the mutations where threonine at 485 is turned into a serine. This is a pretty modest change. These two amino acids are very similar chemically, and yet it has a huge effect on the protein. This is a patch clamp study in a cell of the clone transporter that was transfected into cells in culture. And you can see that when you add bicarbonate, what this shows is that a current is carried that you can measure. This is the current before adding bicarbonate and the current after. And again, the current is occurring because this thing is electrogenic. It's transporting a sodium and a carbonate. But in the mutated protein, there's no current carried. It actually changes the transport from carbonate to bicarbonate, a very subtle change, and it becomes what's called electroneutral, where there's no current change. This is one of the known mutations in this protein. And because it carries sodium and bicarbonate instead of sodium and carbonate, it doesn't carry a current, and therefore it can't be driven out across the basalateral membrane. So you actually end up having sodium and bicarbonate instead of carbonate entering the cell. It's going the wrong way. The patient can't reclaim bicarbonate just from this simple amino acid change that changed the substrate from carbonate to bicarbonate, something we don't think about. People don't even distinguish bicarbonate from carbonate. But bicarbonate is one minus. And so the 1 plus and 1 minus make it electroneutral. There's no current carried, and therefore it can't see the basalateral membrane potential. And since the sodium is 140 here or 150 and 20 inside, and the bicarb's 25 here, a normal cell, I didn't mention, as a bicarbonate about 12 or 15. These two things just enter down their concentration gradient, and the whole transport process is backed up here. I'm not showing NHE3 or the proton pump like before. Now, what about the extrarenal manifestations? They do have abnormalities, as we mentioned, in the brain, or as the patient manifested. The cornea can get lens and corneal opacities, so they can get cataracts. The intraocular pressure is higher, and we have shown in knockout animals that NBCE1 is not only important for bicarbonate reclamation, but it's essential to make an enamel on your teeth. If you don't have NBCE1 functioning normally, you don't make enamel. So it's really important for tooth formation. I won't get into the importance of the protein in all these organs. It's something you can read about if you're interested. But the same transporter that gets sodium carbonate out of the cell is also important in other organs for different reasons. Now, one of the interesting pieces of phenomenology is the pH in the tears in front of your eye. Normally, when you keep your eyes open, the pH is around 7.4, 7.5 in the tear film in front of your eye. But when you close your eyes, the pH drops immediately and then will come back up again. And that's because we constantly have a respiratory alkalosis in our tear film. We're constantly losing carbon dioxide when the eyes are open, and we prevent that when we close our eyes. So basically what you're looking at with eyes open is a constant respiratory alkalosis, and then you close your eye and you have well, you can call it respiratory acidosis or just what it would be with the eyes closed. I wouldn't call this a respiratory alkalosis. I would call this more abnormality, where you have this carbon dioxide loss. And this is shown here. These are your eyelashes here. This is the front of the eye. The PCO2 is about 0 in the tear film, just because you do have carbon dioxide in the aqueous humor inside your eyes and in the cornea, but there's such a loss that you don't really have a carbon dioxide concentration here that's importantly measurable compared to the rest of the system. So we have this loss of carbon dioxide from the inner eye to the outer eye, and that's going to cause an alkalinization, just like it does in your blood when you get a respiratory alkalosis. But it turns out the corneal cells also have NBCE1A, and what NBCE1A does is it transports sodium carbonate out of the cell and keeps the pH from going up too much. So you can think of it as a respiratory alkalosis with a metabolic acidosis, bringing the pH back down. But in patients without NBCE1A here, they don't have the ability to regulate the pH of the cornea and keep it as acidic as it would be. And what happens is you get calcium phosphate precipitating. Calcium phosphate is very pH sensitive. If you go above 7.4, the calcium phosphate comes out of solution. So it's the calcium phosphate coming out of solution that causes the corneal opacities that, just go back here. That's what this is. This is calcium phosphate that's precipitated in the cornea, in the front of the cornea and in the cornea. It's called band keratopathy, if you want to use the correct medical term. But it's basically due to the fact that the pH within the cornea is too high because of loss of NBCE1A transport of bicarbonate out of the cell. So this keeps the bicarbonate and carbonate in the cell low, allowing the pH not to get too high. But when you don't have it, you just have this respiratory alkalosis. So, the ophthalmologist can try to treat this with EGTA eye drops, something to chelate the calcium here. But it is a source of visual abnormalities. So again, impaired NBCE1A is a cause of proximal RTA that you're going to need to know about. It is the cause of the genetic cause of isolated proximal RTA that's been studied in man. In humans, we don't have mutations described yet in NHE3, although knockout models in mice do cause a proximal RTA from NHE3 loss, not as severe as the NBCE1A loss, not well understood why it's not more severe. There's probably other backup systems that come into play. Carbonic anhydrase 2 mutations are well known. They affect both the proximal tubule and the collecting duct, and it's actually a form of either isolated proximal and or distal, or combined proximal and distal, which we call type 3 RTA. That's another set of phenomenology that we'll talk about another time. Not a problem with the transporters. just a problem at the rate at which these two substances can be converted into carbonic acid. It occurs, it just occurs at a slower rate. TAS2 is one of the K channels in the basolateral membrane. It's been knocked out in mice, and they get a proximal RTA. Also, not because NBC1A is not working. They can't generate the voltage across the basolateral membrane as much. So instead of it being, let's say, minus 50 or 60 millivolts, it'll be depolarized. It'll be minus 30 or minus 40. And that slows down the transport of NBC1A, which, as I mentioned, must see a normal voltage here to transport the sodium and carbonate out of the cell normally. And then we have other genetic causes, but they're not only with isolated proximal RTA. And when they're not, we call that Fanconi syndrome. So Fanconi syndrome is a syndrome, and it doesn't really say anything other than we have impairment in proximal tubule transport processes in addition to bicarbonate reclamation. And when you have that, you call that Fanconi's. If you only have bicarbonate transport abnormality, you don't call that Fanconi syndrome. And these are different syndromes due to different mutations in different proteins that we'll talk about separately. And remember, the proximal tubule doesn't just only reclaim bicarbonate, it also reclaims phosphate, amino acids, a whole slew of things, any of which, depending on the syndrome, can be impaired. So another question that comes up then, which you might be able to intuit based on what I've said, is what is the cause of the metabolic acidosis in proximal RTA? Well, a major cause is you have a defect in proximal tubule bicarbonate absorption. It is not like CKD and ESRD where you have a problem with bicarbonate generation. The problem here is in reclaiming the bicarbonate that comes through the glomerular filtrate and having it absorbed as carbonate on the basolateral membrane. Somewhere there's a problem. And you can think of it like a bucket of water where you have water coming in and you do have holes, but now you have too many holes. So, and you have holes that actually allow more water to come out than water coming in. And so the level of the water will fall until the input and output are equal again. As the water falls, there's less coming out. And so you end up having a steady state. Okay, so you can think of it as a similar type of process as far as thinking about it in your mind. You basically just have a ton of bicarbonate initially coming out if you just created the syndrome. And as the blood bicarbonate falls, you have less coming through the glomeruli until you reach a new steady state where the bicarbonate will steady state out at some impaired lower level. At that point, again, remember the urine pH now becomes acidic. It's only elevated initially, and don't mix that up on an exam. They could give you a patient and they'll ask you, was this just created or is this a steady state? And so in proximal RTA, you have to think in those terms, and you have to subcategorize it no matter what the cause into, was it just created like a patient who just got Diamox where the urine pH will be high because there's a ton of bicarbonate still coming out? Or is it someone who's had it genetically all their life? And of course, you're only going to see it in the steady state. You're not going to see it when it was just created in utero. You might see it also with other drugs like ifosfamide that we mentioned the other day, this chemotherapeutic drug that affects proximal tubule bicarbonate transport, or topiramate, which inhibits carbonic anhydrases. The therapy is higher than you might predict in child greater than adult just because they're growing, and you have this changing need for bicarbonate as they grow. The adult needs less, but it depends on the magnitude of the transport defect. And you can give sodium citrate also rather than giving bicarbonate. And some of them are hypokalemic, not all of them. You might want to replace the potassium also. Now, in addition to the bicarbonate reclamation problem, there's another process which most people aren't aware of. And they also appear to have a problem converting glutamine into bicarbonate. Now, Why that occurs is not clear. It's not a problem with glutamine uptake into the cell, like in CKD or ESRD. It appears that it might be a pH-dependent process, or at least people hypothesize that this abnormality. Some of the references are shown below, where because you don't only have extracellular acidemia, you have intracellular acidemia, perhaps. I mean, it's a hypothesis. No one's ever measured it, and that somehow impairs the either Krebs cycle or something, or the mitochondria, somewhere in this process, in these multiple complex processes, you're not generating enough new bicarbonate. Now, we can't measure bicarbonate generation in a patient. We can measure bicarbonate absorption by looking at the fractional excretion, but we don't know what the bicarbonate generation is. But we do, as I was alluding to before, have an indirect assessment of that by looking at the urine ammonia excretion. Because remember, the urine ammonia comes from the conversion of glutamine into alpha ketoglutarate, and the alpha ketoglutarate is the source of the new bicarbonate generation. So when you look at the urine ammonium, you should also be thinking that it's sort of a poor man's way of looking at bicarbonate generation. It's all we have. And so what do we see? At baseline, in some of these patients that have been looked at, you have a urine pH of 6 with an ammonia excretion rate of about 30 millimoles per day. These patients who have metabolic acidosis and a lower urine pH, they're in the steady state, have roughly the same amount of ammonia excreted. That's abnormal. When you have a metabolic acidosis of whatever cause, your urine ammonia excretion rate goes up because the kidney recognizes that it has to generate more new bicarbonate. And so it revs up its glutamine uptake, it revs up the Krebs cycle. This was lactic acidosis, for example. You're generating a ton of new bicarbonate as reflected by a ton of ammonia coming out in the urine. But these patients do not. In fact, it looks like a normal person without a metabolic acidosis. And even more so, when they gave an acid load, you can give ammonium chloride to humans, and it generates a metabolic acidosis. It does so, by the way, because the ammonia that you're giving with chloride, the ammonia enters the liver in the urea cycle and consumes bicarbonate. That's how ammonium chloride creates a metabolic acidosis. It's not because the NH4 released a proton, right? The pK of the NH3 NH4 reaction is about 9.3. So when you give NH4 plus, it stays as NH4 plus. A lot of people get confused. They think the NH4 plus is deprotonating. No, it's that the NH4 plus enters the urea cycle and consumes bicarbonate in your hepatocytes. And now your hepatic venous blood is more acidic. That's how you can create a metabolic acidosis in humans, by giving them ammonium chloride. So that's what they did here. And they created a metabolic acidosis. The kidney recognizes it. It also secretes more protons in general. So the urine pH is lower. The ammonium excretion rate's higher because the proximal tubule is generating more ammonia and new bicarbonate to compensate for the metabolic acidosis. But look at these patients with RTA. They don't generate ammonia normally. It went up above the baseline, but they have impaired ammonia generating ability as reflected by impaired ammonia excretion. And so they inferred from these results that they have impaired new bicarbonate generation also. And that will contribute, like in a CKD patient, to the metabolic acidosis. They don't match their daily hepatic proton load like normal humans would on the same diet. Again, it's indirect, it's inferential, but if you're asked on an exam why patients with proximal renal tubular acidosis, or if someone asks you, have a metabolic acidosis, the major reason is an abnormal absorption of bicarbonate as reflected by the high fractional excretion. But there's a second reason, and they probably have abnormal new bicarbonate generation also from glutamine, possibly because of an intracellular acidosis or intracellular acidemia. And the same thing was seen. People have made NBC1A knockout mice, and they have the same sort of thing as the humans. their urine pH is low because they're in a steady state with proximal RTA. But look at the urine ammonia. And this is a mouse with severe metabolic acidosis. The urine ammonia is way less even than a normal mouse without a metabolic acidosis. So same sort of phenomenology can be replicated in the mouse. Okay, I think I have more cases, but because of the time I've gone over, I apologize for that. And I think we'll stop there for today as far as the issue of proximal RTA and knowing the transport phenomenology and how to think about some of the clinical phenomenology. The key for the exam for these type of patients is that they have extrarenal manifestations. And when there's nothing else in medicine that would cause these abnormalities. If you see a patient with this phenomenology, there's only one thing in medicine it can be, and that's proximal RTA due to NBCE1A mutations. There's nothing else that will do this. There's no phenocopying, so to speak, of this. So these are the extrarenal manifestations that you have to start learning in patients with not only acid-base disorders, but specifically with proximal RTA. Isolated proximal RTA. We're not talking about Fanconi's. Okay, everyone. I think I'll stop there. And if there are any questions about some of the complex pathways that I talked about, please just email me and I'll get back to you. Okay, everyone. Have a great rest of the day.